Okay, my dear friends, we come to the next topic in our list of topics on gastrointestinal diseases, and the disease which we are going to consider is diarrhea. Diarrhea per se is a huge problem in our country, and this can be partially said to be due to our poor sanitary habits and poor water supply. However, there are various other factors which are involved. We will discuss these as we go by. Diarrhea per se is one of the biggest problems in children. So can you tell me which are the two most commonest diseases in children? One, diarrhea, which we mentioned, which is number 2, and the other one is respiratory group diseases. So when we discuss about IMNCI, that is integrated mother, neonatal and child illnesses, we will talk to you in detail regarding these things. But two most commonest diseases in children: respiratory group of diseases and diarrhea. So WHO defines diarrhea as a passing of liquid or watery stools at least 3 times in a 24-hour period. So having passing just one watery stool, 2 watery stools? No, 3. 3 is what we would like to have 3 watery stools in 24-hour period. Then we call it diarrhea. It is a consistency rather than number of stools that is important. So it has to be watery. Now, whether it is an acute or a chronic diarrhea. Acute diarrhea is a diarrhea which has an attack which is of sudden onset and which lasts for about 3 or 7 days. Anything which is lasting more or for 3 weeks or more is called a chronic diarrhea. What happens in diarrhea? Diarrhea results in the loss of fluid and salts. So that can result in dehydration. This is the biggest problem which we face in children, is a sudden dehydration which occurs. And the fluid loss can result in dehydration in the very young as well as in elderly. In India, you have an average adult has a bout of diarrhea about 4 times in a year. So that is the problem which we have, that we have these problems of diarrhea occurring, and any one of these bouts of diarrhea can result in serious problems. It's a leading cause of illness and death among children in developing countries, and children are more likely than adults to die from diarrhea because they become dehydrated much more quickly. See, basically, the child if he loses the same amount of fluids as an adult, remember that the amount of fluids with him is so less, so he will go into dehydration much faster. And the length of the intestinal mucosa which is there is almost as large as an adult, so you have the loss of fluid is very high in children. The loss of 1 liter of fluid from child weighing 7 kgs is more hazardous than similar depletion in an adult of 70 kilos. You must remember that. So just saying that you just lost 1 liter is not enough. 1 liter in an adult won't really make so much of a difference, but 1 liter in a child will make a huge difference. As I said, acute diarrhea is rivaled in importance only by respiratory group of infections as a cause of morbidity in children everywhere in the world, including India. And estimated about 1.8 billion episodes of diarrhea occur each year, and 3 billion children under the age of 5 years die of diarrhea. So many children and so many bouts that we have. That's the reason why diarrhea is so important. So these are the figures which are there of mortality figures due to diarrhea. Where you can use, if you see, we also have a huge amount of Southeast Asia as well as has a huge amount of mortality due to diarrheal diseases. Before the WHO initiated the Diarrheal Diseases Control Program, approximately 4.6 million children were dying every year. Now we have come down to say about 3 million children. So the revolutionary trend came out when we used what is called appropriate technology. The appropriate technology was giving oral rehydration salts and oral rehydration therapy to the children. Really, if you see, it is the fluids and the salt which the dehydration which is being caused, which is causing the death of the individual. But diarrhea per se can be controlled, but this dehydration is the one which requires to be controlled. So the under 5 acute diarrheas which are there, which were in 1979 was about 4.5 million deaths, has come down now to 1.6 million or so. 2002, even now it is approximately similar. Still, acute diarrhea continues to exact a high toll on children, especially in the developing world. So we have got some 2017 statistics. Those are all older statistics, these are newer ones. 1.7 billion cases of diarrhea which are there. 5,25,000 diarrheal deaths annually, and daily about 2,195 deaths every single day. 80% of these children die in the first 2 years of life. So it's you can, if you count out, you can say about one child dying every 15 seconds. The number of episodes in diarrhea in India is said to be about 1,92,943, with a morbidity rate of 1.7 per thousand. 10 to 25% of children are ill with diarrhea for their first 3 years of life. You see, every child goes through diarrhea, every single child goes through diarrhea, and so the number of episodes is what? Every child goes through about 3.3 episodes per year, that is worldwide. Start looking at developing countries, is much more. Where episodes are frequent, young children may spend more than 15% of their days with diarrhea. So, especially in the malnutrition children, this makes a huge difference. In health institutions, up to a third of the total pediatric admissions are due to diarrhea. Diarrhea, respiratory disease. Most of the admissions are due to that. So these are the DALYs which are there. Disability associated life years, which you can see again very high, 20,299 in the Southeast Asian region. So what causes diarrhea? You have viruses, you have bacteria, you have others. Viruses, the most common virus in children is rotavirus. Otherwise you have astroviruses, adenoviruses, calciviruses, coronaviruses. You talked about COVID. COVID is one of the symptoms is diarrhea. Norwalk viruses, enteroviruses, all the viruses which cause diarrhea. The bacteria which can cause diarrhea, which is very often also Campylobacter jejuni, E. coli, Shigella, Salmonella, VIBRIO cholera, which we will discuss in detail in the next series of lectures, and Bacillus cereus. Also, you have the roundworm infestation into Histolytica, Giardia intestinalis, Trichuris, Cryptosporidium, and other intestinal worms. All these can also result in diarrhea. Persistent diarrhea is one of the main clinical signs of AIDS also. AIDS decreases immune system in the body, and hence you can have diarrhea. Children with measles also run a very high risk of developing fecal diarrhea. Diarrhea can caused by due to parenteral infections also, which can also result in diarrhea. Malnutrition may lead to certain nutritional diseases which are associated with diarrhea. Malnutrition results in decreased immunity, results in diarrhea, results in further malnutrition. Diarrhea in newborn is unusual because it has the immunity from the mother, and if the child is only having breast milk, then you can expect that the child will not suffer from diarrhea. Otherwise, it should be some inborn error of the person. So as we said, man is the reservoir of most of the infections: E. coli, Shigella, Vibrio cholera, Giardia. The human and animal feces are the infections in Campylobacter jejuni and Salmonella. Common in children between 6 months and 2 years. Incidence highest in age group 6 to 11 months when weaning occurs. That's the time when you have children getting, if a child is breastfed, there's no question, there's less chance of infection. Nutrition, the diarrhea is common among the malnourished, and there's a vicious cycle which is there. I'm sorry, the slide has gone out of focus. Basically, malnutrition causes decreased immunity, and decreased immunity causes diarrhea, causes further malnutrition. It's a vicious cycle. The contributing factors are poverty, incorrect feeding practices, prematurity, immunodeficiency, lack of personal and domestic hygiene. So basically, poverty is a big problem which is there. Poverty itself is the cause of incorrect feeding habits because the person is uneducated, also is unable to spend enough time with the child, has got to do go in for some manual labor, and that can itself lead to prematurity. Prematurity and immunodeficiency go together, or you have other immunodeficiency conditions. And lack of personal and domestic hygiene is one of the main causes where a person can land up with diarrhea. Although diarrhea occurs at any time of the year, outbreaks of diarrheal diseases follow a seasonal pattern, and you'll be surprised that it is more in the dry months when there is decreased amount of water and contamination of water is more, and also during the winters when you have decreased consumption of water by people, or possibly because of clustering of people, that you have more cases of diarrhea occurring. So fecal-oral route is the most commonest cause of transmission. It can be waterborne, it can be foodborne, or direct transmission through fingers, fomites, and dirt. So all these can result in transmission of the disease. As we mentioned, the diarrhea disease is ranked after ARI, defined as intestinal disorder characterized by abnormal motility and fluidity of fecal evacuations, passage of loose watery stools more than thrice in 24 hours. Breastfed infants pass soft semi-solid stools, and hence the change in consistency and character of stools is more important in the diagnosis. Breastfed infants, how do they get the infections? Because they're crawling on the floor. When they're crawling on the floor, they try to pick up things from the floor and then land up with infections. What are the different types of diarrhea? The four clinical types which we have: one is an acute watery diarrhea, which involves passage of loose, watery stools without visible blood. Vomiting and fever may be present, and duration is less than 14 days. Results in dehydration and undernutrition when food intake is reduced. So, undernutrition because food intake is reduced. The common agents which are there are rotavirus, E. coli, Shigella, Vibrio cholera O1, and Salmonella. These cause acute watery diarrhea. The bloody diarrheas are basically bacterial in nature, mostly involve diarrhea with visible blood in the feces. Complications are anorexia, rapid weight loss, sepsis, and damage to the intestinal mucosa. Agents: Campylobacter jejuni and Shigella. Persistent diarrhea and chronic diarrhea. Please remember the difference between persistent diarrhea and chronic diarrhea. Persistent diarrhea is diarrhea which lasts more than 14 days. And this generally is watery but may be bloody diarrhea. This, since it is already 14 days since the person is suffering from the diarrhea, is marked weight loss and risk of dehydration is there. A large number of microbes and viruses can be involved. Cryptosporidea may play a greater role because in persistent diarrhea this is common. Chronic is when you have recurrent bouts of diarrhea or long-lasting diarrhea. These may be due to non-infective causes. You've nowadays got irritable bowel syndrome and various other systems problems which are there, gluten insensitivity, various other problems which can be confused with persistent diarrhea. So a good investigation is necessary. Diarrhea with severe malnutrition. Diarrhea can be with marasmus, kwashiorkor, and nutrient intake declines by as much as 1/3 during the last few years. Loss of nutrients due to diarrhea, vomiting, and this can result in immune deficiency, can result in dehydration, systemic infections, heart failure. So this is what we talked about: predisposition resulting in small intestinal dysfunction, chronic diarrhea, malnutrition. This malnutrition can create pancreatic and gastric dysfunction, and because of specific this malnutrition, there are specific deficiencies. These specific deficiencies, especially zinc, can result in further immune deficiency, which can result in infections, result in malnutrition. All a vicious cycle. So what is the acute diarrhea? What are the causes? The causes of acute diarrhea we have mentioned. Bacterial causes are Campylobacter jejuni, VIBRIO cholera, Shigella, E. coli, Salmonella. Viral are rotavirus, astrovirus, adenovirus, enteric viruses, pneumogruppoviruses. Parasitic being Giardia, M.B.B.S histolytica, Cryptosporidium and intestinal worms. And toxins such as Staphylococcal, Bacillus cereus and Salmonella. Chronic diarrhea, the infective organisms are generally parasites, worms, Salmonella, and non-infective malabsorption states like celiac disease, lactose intolerance, fructose malabsorption, or radiation fibrosis. Chronic inflammatory diseases also should be considered like ulcerative colitis and Crohn's disease, and others like ischemic bowel disease or cancer of the large colon, and nowadays IBS, irritable bowel syndrome. So what is pathophysiology of diarrhea? You've already studied this and you did your pathology, so just a short revision. Fluid present in the bowel is about 6 to 9 liters, mostly gets reabsorbed. Stool contains about 100 to 200 ml per day. Any increase in this can result in diarrhea. So what can occur is if you lose too much of water and salts, you can result in dehydration. Fluid is lost from the bloodstream. Once you get dehydration, fluid is pulled in from the bloodstream. So the heart tries to compensate by beating faster, so you've got tachycardia. Fluid is drawn from body tissues in circulation to essential areas, closed down. So you've got fluid coming in from the circulation, from body tissues. So you have a dry skin, you have pinching of the skin can result in, we'll talk about it, how we can show signs of diarrhea. Limbs become cold and pulse is weak. There can be circulatory collapse, urine volume decreases, consciousness is impaired. In cholera, we also get acid-base balance disturbance and acidosis which will occur. This is the thing which shows, I think the slide is too small for you all to see, so we'll just run across it. So one should remember the difference between secretory diarrhea and invasive diarrhea. Secretory diarrhea is caused by VIBRIO cholera, EC, the toxigenic variety of E. coli, and toxins are released which stimulate the enzymes adenyl cyclase. This stimulates outpouring of sodium and chloride ions with water, as well as the cell also dehydrates, causes watery diarrhea, leading to dehydration, circulatory collapse and circulatory failure. In invasive diarrhea, the pathogens colonize and invade the mucosa of the intestinal tract. Cells die, the blood vessels rupture, white cells along with blood and tissue fluids are excreted, and dysentery results. These are seen in shigellosis or rotavirus functions both as in the secretory diarrhea as well as the invasive diarrhea. During diarrhea, increase in loss of water and electrolytes is seen. If it is not replaced, you can get dehydration. The volume of fluid which is lost in stool is 5 ml per kg, 200 ml per kg in about 24 hours. Loss of 70 to 110 ml of per liter of water deficit, potassium and chloride losses which takes place. These are the ones which result in dehydration, as well as you have various problems due to decreased electrolytes. So as we mentioned earlier, dehydration takes place much faster in infants and elderly, and patients may or may not have fever. Now, how do you grade the diarrhea? The degree of dehydration indicates the amount of fluid which is there, fluid loss. So early or mild dehydration can result in extreme thirst, decreased urine output, weakness, cramping, irritability, warm, dry skin, crying with few or no tears, dizziness, dry mouth and dry tongue. Moderate to severe dehydration, you can result in low BP, sunken fontanelle and dry eyes, wrinkled and inelastic skin. So you pinch the skin, the skin does not go back. Rapid and deep breathing, fast, weak pulse. And severe dehydration, the effects are more pronounced, hypovolemic shock and death might occur. So early, moderate and severe. We'll talk about this further in detail when further slides. This is how we will classify it. We look at the condition of the patient. If he is well alert, there is no dehydration. Further dehydration, restless, irritable, and then he can become lethargic or unconscious. Eyes, if they are sunken or very sunken, denotes the scale of dehydration. Tears, if they are absent, there is dehydration. Tongue and mouth are dry or very dry, dehydration. Feels thirsty, and as the dehydration increases, the patient is unable to drink. So when severe dehydration, the person is unable to drink, that will be a problem. Pinching of the skin, it goes back normally, that is no dehydration. Goes back slowly, that is some dehydration, goes back very slowly. Actually, what you can do is, if you got a grandmother who is very old, you can try and pinch the skin of the grandmother. You will see that it doesn't go back. It's not dehydration. It's because of loss of fat in the old lady that this takes place. But in younger people, because of dehydration, you can have the same features. So yeah, like for all the features in a child, you've got sunken fontanelle, sunken eyes, dry mouth, the skin fold which is there will not go back, he stops playing, he has loose motions, and he is listless, he is irritable, may have a fever. As we were saying, the most common one is rotavirus. The others, we have bacterial causes which are there spread around: E. coli, Shigella, Clostridium and Vibrio, and in some cases Cryptosomes botulinum. Rotavirus dominantly is the one which is most common. Single most important cause of diarrhea in infants, rotavirus. It cause of severe and life-threatening diarrhea under 2 years. Nearly all children are infected once before age of 2 years, and repeat infections are common. Spread is from person to person. Virus particle replicates in the villi, epithelium and small bowel, causing villi destruction. And the loss of the villi and replacement with immature epithelium causes secretion of water and electrolytes. Loss of the disaccharide enzyme leads to reduced absorption of dietary disaccharides. Recovery occurs when regenerated epithelium matures, more severe compared to other viruses. Adenoviruses, severe outbreaks have been seen associated with children and can cause severe infection in children. Coronavirus has been seen in diarrhea associated with malnutrition. Other viruses, Norwalk and various calciviruses and other viruses can also cause bacterial infections. You have ETEC and VIBRIO cholera and the toxigenic strains. Basically, we've already covered these. Let me just run through it because we've got shortage of time. ETEC, EPEC, and EIEC, you studied it in detail in your when you were dealing with different varieties of E. coli which are there. You have ETEC, with toxigenic strain, you've got watery diarrhea. In EPEC, you have got fever, abdominal cramps, tenesmus, and watery diarrhea again. And in the invasive variety, you'll have diarrhea-like symptoms and which has got a high mortality. Nowadays, cholera is mainly caused by the LTOR variety. You've got various stages: evacuation, collapse, and recovery. We'll talk about it when we talk about cholera. Shigellosis also can occur as regional epidemics. And basically, you have a watery diarrhea with some cases of blood and abdominal pain, vomiting, and fever. So we have had large outbreaks which have taken place in our country. Nowadays, we do not have such large outbreaks, fortunately. Salmonella and VIBRIO you can see that they are very common among the Gangetic belt which is there. Nowadays we have been able to control VIBRIO to a large extent, but you still have LTOR VIBRIO coming up sometimes. Campylobacter, which is there, is also results in large amount of watery diarrhea or dysentery, and these are seen. Salmonella can cause invasive diarrhea, just like Shigella. Protozoal diarrheas which are there are generally self-limiting and not very severe. We will not go through this. We just mentioned about traveler's diarrhea. Traveler's diarrhea is a condition where, especially when you have foreign tourists coming in, they come with diarrhea, and you find that they call them in various terms. They call it Bombay tummy. They call it various other. This thing, traveler's diarrhea, is when person has 3 to 4 unformed stools in 24 hours and is associated with urgency, abdominal pain, and vomiting. Pathogenesis will depend on the organism which is causing it, and in mild cases you got 1 or 2 unformed stools, and moderate cases more than 3, and severe cases much more. Basically, AIDS also can result in decreased immunity, and once there's decreased immunity, you have chances of other infections creeping in, and that can result in colonization of the gut, etc., and you can have diarrhea. Chronic diarrhea is one of the features which we consider as a pointer that a person has got HIV infection and should be looked into further. Hospital-acquired diarrhea is also another problem which can occur, and hospital-acquired infections are a different chapter in itself. Food poisoning can result in diarrhea, and this is can be due to staph infections or Bacillus cereus, the two most commonest infections. Salmonella, Staph, and Bacillus cereus are the three most commonest infections which are there, and they can result in huge food poisonings. Salmonella poisoning are mainly due to processed foods, storage of processed foods, and cause acute colitis. And in a case of staphylococcal, you've got abdominal cramps, vomiting, diarrhea. You may have fever from the toxins which are there. Bacillus cereus and staph are very difficult to differentiate. Then you've got botulism due to Clostridium botulinum, and this can be due to when you get it from pickles, etc. And this can result in dysphagia, weakness, blurring of vision, very dangerous sort of food poisoning. Clostridium perfringens can also cause food poisoning, results in abdominal cramps, and there's a rapid recovery, and death is rare. Okay, Bacillus cereus, I've told you there are two forms of it, emetic variety and the diarrheal variety. So one has to see which variety which is there. And lab diagnosis, we have to start looking at it from the angle of whether it's primary healthcare or intermediate or a large hospital. Basically involves taking a good history of the individual and then collecting the sample. The sample can be looked for culture as well as for blood, mucus, worms, and tapeworms, and various other worms. Water specimens should also be collected. 1 to 3 liters should be collected in sterile bottles, and you can check it for cholera as well as other organisms. Food samples are very important. Suspect food items should be collected and sent for analysis. What happens normally is whenever you go to a food poisoning site, you will find that everything has been cleaned up and you can't get any samples. That's the biggest problem with food poisoning. Transportation should be done in stored or carry-bearer medium, and you should ensure that you store the sample well. Phosphated buffer saline is also used for rotavirus, and you can try and collect more than one sample. You do a macroscopic examination, the microscopic examination. You can do a hanging dog preparation for cholera, and you can culture it in McConkey's agar and then look for colonies of E. coli or various other organisms. Biochemical tests can also be carried out. Okay. So the Diarrheal Diseases Control Program of WHO was started in 1980, and basic idea was rehydration. So we had long-term and short-term goals of the program. The short-term were measures which were there was oral rehydration, homemade solutions. You see, homemade solutions are one of the best things which can be possible. You can look at whether it is a normal kanji or whether you want to make a solution from sugar salt solution and give it to the child. Whatever it is, homemade solutions should be tried out, because those are readily available at the houses. And the very important fact is that you must ensure that whatever water is taken for dilution should be free from contamination. Oral dehydration therapy is cheap, simple, and effective way to treat dehydration caused by diarrhea. So here we have 8 teaspoons of sugar, 1 teaspoon of salt, and 1 liter of water. When I was doing my M.B.B.S, we didn't have spoons were not so common in villages. So we were told that at that time these bowls also were not there for collecting the water in the villages, but they definitely had a lota. So we used to call it ek lota bhar pani, ek muthi bhar chini, ek chutki bhar namak. So this was what was being done in villages: lota bhar pani, muthi bhar chini, and chutki bhar namak. But the water, the biggest issue is the water. You are not going to use the same water. If you are going to use the same water which has caused the diarrhea, you are not helping any. So ensure that the water is boiled and cooled first. Boil the water and cool the water, and then do this whole procedure. The various types of ORSs which are there, composition with ORS with bicarbonates and ORS with citrates. Basic idea is that we want to decrease. Earlier we had the bicarbonate ones which are there. Then we came up with the citrate ones, and nowadays we talk about low osmolarity ORSs. The idea being that if you have a hyperosmol solution which has been given, you will have more outpouring of fluid into the gut than an inpouring from the gut into the system. So a low osmolarity ORS is something which we should aim for, whether it is citrate or whether we use something else. So this is the standard solution. Earlier used to be 3.5, 2.5, 1.5, 20. This I remember when doing my PG. I remember 3.5, 2.5, 1.5, 20 is what we used to keep on rattling out, and 90, 20, 80, 30, 111. Sodium, potassium, chloride, bicarbonate and glucose. You should also be able to rattle this out and say that this is the old ORS. The newer ORS which is there is low osmolarity. You can see the figures in your book. Acute diarrhea normally only lasts for a few days, so if you give ORS solution, the patient will recover. The patient may not require any antibiotics. How do you assess the dehydration? We have already mentioned it. And the water deficit is somewhere between 50 to 100 ml per kg body weight. Child is known. So what we can do as far as giving ORS is concerned is there's a chart which is there by which we can decide as to how much ORS to be given from 4 months to 15 years. Charts. You must ensure that a graded amount of fluids is given. You cannot cause overhydration by ORS. Please remember that. There's this whole concept which says that don't overhydrate the child. You cannot cause overhydration by ORS. If you're giving fluids IV, you can overhydrate and can kill a child. So be very careful. You should give IV fluids only if the child is unable to take fluids orally. And once given the IV fluids, the maintenance should be done preferably only by ORS. So where we talked about this, wash the hands, take the water, boil it. Very important to boil it. Then mix the packet of the ORS and give it to the child. These are various things which are available with nutritionists where you can use for your making the ORS. How do you give the ORS? You give the child 1 teaspoonful every 1 to 2 minutes. Keep on making the child or make the adult sip, and you estimate the amount which has been given in 4 hours and keep on giving. And in the meantime, please do not stop breastfeeding. Breastfeeding should be continued. Non-breastfed child will have to be given more water also, 100 to 200 ml more water. Intravenous is only if the child cannot receive or the adult cannot receive oral ORS. Persistent vomiting is there, high rate of purging or severe dehydration and shock, then you can give. You can give a regular lactate, that's the best available which is there. Or you got a DTS, as it's called, diarrheal treatment solution, which is basically similar to Rigor, but it has sodium chloride 4 grams, sodium acetate 6.5, potassium chloride 1 gram, and glucose 10 grams in 1 liter. 100 ml per kg is to be given. We will talk about dehydration when we talk about IMNCI. We will be talking about rehydration in children. In detail, we'll talk about it. Maintenance dose. After the initial deficit is corrected, you get mild diarrhea, you get 100 ml per kg per day, and severe diarrhea, you give 10 to 15 ml per kg per hour. Appropriate feeding should be done during the episodes of diarrhea. Don't ensure that you don't make the child malnutritioned. and don't stop the breastfeeding for the child. So these are the things which should be given as far as chemotherapy. We should restrict chemotherapy as far as possible. Give only ORS, you'll find that the patient is alright. Neomycin damages the intestinal mucosa and causes malabsorption. All the opioids which we give for decreasing the colic can be dangerous for children and dysentery because of decreased intestinal transit time. Maternal nutrition is very important, and child nutrition, maternal nutrition, so it will decrease the birth low birth weight, also will give enough, the mother will give enough milk. During the weaning practices are very important to check what are the weaning practices. Supplementary feeding should be done, and sanitation should be looked at, improved water supply, excreta disposal, food, disinfection of stools which are there, personal hygiene, hand washing. Everywhere we talk about hand washing before eating and defecation, fly control, and immunization, especially against measles, which is co-associated with this disease and causes harm, and health education of workers and is very, very important. That's all that we have for you. I tried to run through it because we started this class late, so I had to run through this. Sorry that we had to run through it because I have a meeting also after this, and so I wanted to finish it off as fast as possible. So all the best, and we will be discussing cholera next time, so please read up and come. We had some problem with technology. Technology is a problem. The net was down, and hence we were unable to have the class early. So please ensure that you read up your topics. We are also now working out as how to do your internal assessment, and your internal assessment will be based on what you will submit. So we are making out some things for health education, how we can run a health education program, and so we will be telling you to make some things for health education. Based on that, we will give you marks for your internal assessment.